Hi, welcome guys. Welcome everyone joining. I'm just going to give about 2 minutes before we start. Where's everyone from? Why don't you write in the chat where you're from, so you can have a rough idea where everyone is from, and also write what you do. So if you're a medical student or you're a doctor or in a different profession. UK, Ireland, just graduated from UCL, great. So let's give it, medical student South England, excellent. Fine, should just give another couple of minutes before we start. Can you guys see my screen? Great. Okay. Minimize this. Fine, perfect. So should we? Let's make a start. It's just 7:01. So my name is Basir Kunduzi. I'm a FY2, Foundation Year 2 in the East of England Deanery. And well, actually, I just finished my foundation training. We've just got a couple of months of work going, work to do. But officially, we've got our ARCP signed off, which is a sign off that you do at the end of each year when you start working as a doctor. So officially not a foundation doctor anymore. So, and I thought I'd give this talk because I've worked in general surgery. Surgery is of interest to me. And I thought for the foundation doctors and medical students, because inevitably you will work in a general surgery ward. And also to give you a flavor of what it means to be an F1 and the things you should look out for and the things that hopefully make you stand out as an F1. The talk is relatively short compared to our previous talks on the acute abdomen and the vascular talk we had. There's not too much medicine in it, but rather just on what you should expect as of being an F1 with some tips and tricks. As I said, my name is Basir Kunduzi. You can find me on Instagram, Twitter, LinkedIn, most active on Instagram, and Bas Kunduzi. I'm also the co-founder of MediGate and Cut the Stitch, the page that is hosting these talks. So please follow us all on Instagram, on all 3 pages, and hopefully we can give you some benefit and bring some value to your medical careers. Fine, let's start. So there we go. So what is the role of FY1 in general? So when you graduate from medical school, what you hope your role is that if you're interested in surgery like me, that you in theaters, that you're in theaters and you cutting people open, you putting lines in, you asking for a scalpel and shouting code red and what do they say in house, like stat this, that. So that's what you actually hope for, right, when you graduate from medical school. But what you actually get is something like this. So a lot of note taking. So your role as an FY1 foundation year one, you're the most junior on the team, the team of doctors. And what you do is you do a lot of note taking. Now, note taking can be through, depending on the trust you work at, it could be digitalized. So it could be on a computer typing, on a laptop typing things, or you could be making actual physical notes. There's a lot of trust. So my first trust when I did my general surgery job, everything was paper written. So you pick up the notes in the morning and you go be prepared. So be on time, go prepare the notes, and you follow the consultant or the registrar around on the ward round and you make notes. And the things that you write in those notes, just to make you aware, is things like Mr. So-and-so, your consultant's name, ward round on this date during this time. And then you write, for example, this patient stable, patient this, and you write basically everything you try to, you see of the patient. So the patient's sitting, the patient's stable, the patient said this, the consultant asked this, as much as you can, as concise as you can, because obviously you don't have that much time to do it because everything goes very quick, especially in general surgery when you guys start working, or those of you who have already worked in general surgery or about to work, you realize the ward rounds are much, much faster than other specialities, especially more faster than medicine. And I'll have a breakdown of what your work day might look like when you start working. Second thing, taking bloods, ABGs, VBGs, just your normal full blood count using these, etc. Now, again, some trusts, obviously you've got phlebotomists coming in. Sometimes you might request the blood later than the phlebotomists have arrived, and the nurses can do them. Or some trusts, the doctor is expected to do it. But I think a lot of places, the nurses are supposed to do it, but sometimes they're they're busy. Or they can be tired, of course, anyone can be tired, but they might be busy with other stuff and you'll be asked, or there might be a patient that's quite difficult to bleed, so the nurses attempt and then they ask for a doctor. And I would say, especially at the beginning, when you start, try to do a lot of these things yourself, because believe me, it really helps building your confidence in procedures, allowing you to, for example, really take blood from difficult patients. And it's a skill that you must have and that you need to have. And I don't think it's good as a doctor to lose this skill, or any skill in that matter, but especially blood taking, ABGs, VBGs, and things of that nature. By the way, throughout this talk, any questions, please ask them in the Q&A section and we go through them at the end. Finally, keep the nurses happy. What do I mean with keep the nurses happy? Now, nurses are part of the medical team looking after the patients, right? They spend more time with the patients than you do, generally speaking. So you always have to make sure you work with them in a team. Don't go in there as a doctor acting arrogant, which I'm sure none of you will, but just as an advice, thinking you've studied 5, 6, 7 years of medical school, that you know better. Because just as a heads up, there will be nurses on the ward that will have looked after patients within that specialty for 5, 6, 7, 8, even 10 years. So it's only logical that their knowledge of that specialty is more than you when you start. So be nice, be humble, ask questions, and keep them happy. And another way to keep the nurses happy is by doing what they say. So what, for example, if they ask you to do a TTO, a discharge letter, which we will come to, is to go and do it. So if you want to have a break and you're tired and that kind of stuff, just let them know, I'm going for a break. I'll be back in 15, 20 minutes. Just keep them in the loop, work as a team. And that's all they expect of you. And if someone makes a mistake or someone doesn't do something that was planned during the ward round as a doctor, then deal with it in a way that you like to be dealt with. So, for example, maybe pull that nurse to the side and say, why was this not done? Or is there any reason, anything I can help you with, etc., etc. Just like you would hope they will do to you when you make a mistake, and you will make a mistake as a doctor. That's guaranteed. So, next one. So, again, as I said, so you're part of the ward team. So you are the doctor as FI1. It is very unlikely that you will spend any time in clinic, in theater, or anywhere else. Most of the time, you are on the ward looking after the patients on the ward. So the patients on the ward are your responsibility. You need to know who they are, why they're here, etc. We'll go over that in a second. You carry out the jobs that are generated during the ward round. So no, you won't be by yourself. Obviously, there will be other F1s, there will be SHOs. There will be physician associates, maybe specialist nurses that will help you with carry out these jobs, and then you will carry, obviously, just your responsibility to make sure that they're done. And sometimes you might be by yourself. So the SHO might be ill, your other F1 might be on annual leave, and it's you taking care of, say, 15, 20 patients. So you have to make sure those jobs are done. You ensure that the nursing staff are aware of the patient plans. So that goes in keeping with keeping the nurses happy, because what happens sometimes when you do go on a ward round, you follow the consultants. The nurses might be busy doing other things. They might be busy giving medication or other things, so they're not necessarily can come and follow you on the ward rounds. So good practice, sometimes they might not even ask of you to do this, but it's good practice to maybe after the ward round, just go find the nurses that are responsible for the patients. Sometimes nurses are like one nurse is responsible for 3-4 patients on a ward. You find them, so who's responsible for patient 1, 2, 3, and you tell the nurse, this is the plans that we made with the consultants. So we're going to do bloods on this patient, and we're going to refer to this specialty, and hopefully they'll be ready for discharge tomorrow or the day after, or today. And you go and so on, and you cover the whole ward, and you go through all the job plans with the relevant nurses. And that way you ensure that they are aware of the plans, and that way you ensure that whatever things that they need, the things that they need to do, that they're aware of it. Because if you don't do that, and there's miscommunication, they're not aware of it, and you come later on in the afternoon, and the patient says, for example, the plan was to TWOC the patient, to remove the catheter. It's called trial without catheter, to see how the patient does if they pass urine by themselves. But because you haven't communicated that well, you come in the afternoon, it hasn't been done. So that delays the discharge of the patient, that delays the management and care of that patient. So that is really good practice to do in all your jobs, regardless of general surgery, medicine, whatever you do. Ensuring the nurse, I mentioned that, and referring and ask for advice from different specialities. So you work on a general surgery ward, the patient presents with a problem. For example, they develop a rash. As an example, they develop a rash, or their heart rate goes into a rhythm that is irregular. Medicine has become such that everything is very into their own specialty. As soon as it diverts slightly, you get other people involved. That's how it is in the UK, and I think most Western medicine, how it's run. So make sure you, so your job would then be, for example, your consultant will say, oh, I'm not sure what this rash is. Dr. So-and-so, could you please speak to dermatology and ask for their advice? So then your job after the ward round, one of your jobs is, obviously you prioritize your jobs, but one of the jobs would be you call dermatology registrar and call consultant, or call, sometimes they're in a different hospital, sometimes they're in your hospital, and you say, this is our patient, this is what's happened, could you please come review them, or can I just ask your advice on what we should do next? Likewise, you might call cardiology, hematology, etc. And finally, the thing that you will probably do most, which is a pain, but it's got to be done, and unfortunately as an FY1 you will do most of it, is discharge letters and TTOs. Now, sometimes they're mentioned, and just as something, again, these are very basic things, but sometimes they make a difference in knowing them. So sometimes when in certain trusts, when people say have TTOs, they mean a letter and the medications. Sometimes when they say discharge letter, they mean letter and the medications. And some hospitals, they split them up and they call discharge letters the letters that you write when the patient is being discharged, as in why they were here. So a letter to the GP and a letter for the patient to know why they were in hospital and what's happened to them. And a TTO is basically medications that they take home with them. Because sometimes they come into hospital with like a list of medications, but the consultants decide, okay, they don't need these medications anymore. They don't need these blood pressure medications, for example, or these painkillers anymore. They're fine. So you kind of stop them, and you give them a list, and the pharmacy dispenses a set of medication that they go home with, and that's the TTO. So that's basically, to be exact. However, as I said, in a lot of places, they get mentioned together. Fine. Next. So that's basically the role of an F1. But what makes a good F1? What makes a good F1? I've been thinking about this quite a bit, obviously, during F1, during F2, asking my colleagues. And one, if nothing else, one advice that you should always keep in mind, and this was mentioned to me when I started F1, just as in a passing. So we asked someone for advice, we were just walking by during induction, and this is what they said: own your patients. What do I mean with own your patients? So let's go through it. Why are they in hospital? You should know when you go during the ward round, because your consultant or registrar, they're not always on the ward, but you are on the ward. So you should know why each patient that you're responsible for, your team is responsible, why are they in hospital? What procedures have they come in for? Did they come in because of an emergency? Did they come in electively? Did they come in for a complication of a previous procedure? What was the reason? And this is in general surgery, but also in different specialties, obviously. So this advice is in general. Again, since we're talking about general surgery, are they pre-op, are they post-op? You go see a patient that's coming for elective surgery, or they've come in for an urgent surgery, but their surgery has been delayed, and you should know, for example, so this is a pre-op patient, a post-op patient, and if it's a post-op patient, so post-operation, were there any complications during the operation? Was there bleeding? Was there things that the surgeon came across that wasn't expected? And you can read that within the operation notes. And usually, obviously, when a patient has, say, a major complication, you will be aware of it. The nurses will be aware of it, but it's something to keep in mind. Are they stable? If not, what is the problem? Do they have low blood pressure? Do they have a fast heart rate? Do they have a slow heart rate? Are they desaturating? Are they on oxygen? If they're stable, I mean, with these things, you don't need to know the exact numbers of each patient in your mind. Like, I'm not trying to frighten you. You don't have to know, for example, each patient's heart rate, blood pressure, and so on and so forth. But, for example, if there is a patient that is unstable, that is, for example, has a low blood pressure, then it's good practice, again, to know that your consultant asks, or your registrar asks, like, yeah, that patient X is unstable and the blood pressure is 90/60. We're giving them some fluids, for example. So it's just good to know that patient. The other patients, for example, if they're stable, then they don't need to know, for example, the exact systolic blood pressure, for example. Any infections? If so, what antibiotic is a patient on? I mean, that's happened to me sometimes. We've been on the ward round as an F2, I must say. And the patient's like, okay, this patient's infected. What antibiotic on? I'm like, what were they on again? Was it tazocin? Was it comoxiclav? I don't know. And my registrar actually pulled me to the side and said, by the way, you know, like when the consultant asked you on the ward, you should know. In a very nice, friendly manner, of course, he advised me. And since then, obviously, I've taken that up that, okay, fine. If a patient has an infection, it's not all the patients that have infections, but the one or two that have it, then I should at least know, because you need to know, are they on IV tazocin? Are they on oral comoxiclav? Because that, again, impacts the decision of the consultant on whether the patient should be discharged, how long they should stay in hospital. Because if the patient's on IV antibiotics, then usually, of course, you don't discharge them with that. But if they're on oral, then you might consider, like, the inflammatory markers are coming down, the patient is recovering well, they're oral antibiotics, they can go home on that and take a week of oral antibiotics at home and recover further. So any significant derangements in the blood markers. Again, not every patient you need to know about every single blood marker. However, if a patient, for example, has a AKI or a deranged Usinase, then you should be aware, for example, like, this patient, the kidney functions are deteriorating. The creatinine was 150, whereas previously it was 80, something along those lines. Just that one patient or those two patients that have these problems. And the thing is, you don't have to memorize all these things. If you're well prepared with your notes, if you're well prepared, for example, with the notes that you might print off beforehand, and you look through your list, okay, I saw these patients, let me put a mark next to them, or let me highlight the significant blood markers or stats, or, I mean, the observations, then you can just read it off the sheet, of course. But it's all about being prepared. And are there any other specialties involved? Again, if a patient, for example, the consultant asks you to refer to a different specialty for advice, or because you finished your care within your specialty, so the patient has had general surgery and now is recovered from that, but however, they still have some heart problems, but now they're under cardiology. So the consultant needs to be aware of that, or they have input, but they're also under joint teams. So they're under cardiology and general surgery because of two different problems. And if the consultant's aware of that, then that's good as well, because then we know the plans of the other specialties. Again, impacts discharge, impacts care. So let's move on. So, topic at hand. What is general surgery? So the NHS Health Careers says general surgeons employ a wide range of knowledge and skills to perform surgery, often in emergency situations. There's frequently an emphasis on acute abdominal problems. General surgery, when you hear about it, you think of the abdomen, and that's what general surgery is. Obviously, everything in surgery, medicine, as I mentioned before, has become a niche, has become very specialized. So within general surgery, when you say you work on a general surgery ward, depending if you work in a DGH or a tertiary center, a big hospital, small hospital, depends on what within general surgery, what ward you're working on. The list that you see in front of you, so upper GI, colorectal, endocrine, breast, transplant, vascular, and trauma. And obviously vascular, I'll mention in a second as a side note, are all part of general surgery. So you as an FY1, your job might be advertised as general surgery, might end up working in any of those wards. And upper GI also includes HPB, which is your the hepatopancreatobiliary surgery, so liver and pancreas and things like that. And so you might be working on any of those wards. Vascular, since 2012, is not part of general surgery anymore. It was in the UK. However, so I've had colleagues who said, for example, they were expected to work on a general surgery ward, so that's what they like opted for when they chose their jobs. However, they ended up on a vascular surgery ward with maybe some general surgery cover during on-calls. Yeah, basically those are the wards that you could potentially end up working in. And obviously the types of surgery that they do, the procedures that they do, laparoscopic, open, things like that. That's, I think, too much detail for this lecture. Something, feel free, you can ask me during the question and answer session or later on Instagram or anywhere else. But yeah, that's generally what is included. Trauma, as I said, also just to mention trauma, certain centers have trauma centers like King's in London. Addenbrooke's is a trauma center. I'm in Cambridge at the moment. So you might have ended up working in a trauma unit, and trauma sometimes is associated with orthopedic trauma and orthopedics, but sometimes also there's general trauma, like visceral trauma and things like that. So that's that. So the surgical team. Who does the surgical team consist of? The surgical team consists of medical students. So sometimes yourselves as medical students, you're part of the team when you're attached to a general surgery ward. So you're part of that surgical team, because often you want to feel like that. And I think we should obviously get into that culture of making medical students really feel part of the team and teaching them like that, because sometimes medical students come on and you guys might have experienced it. I certainly experienced it. You go into the ward and you feel kind of foreign, like, what am I doing here? I'm not. And the doctors kind of brush you off, like, oh, you're just a medical student. Do you want to take some bloods and this? Do you want to do this? Whereas, for example, if you're really part of the team, then when you start working, you already know what it feels like. Foundation year 1 doctors. So as far as being qualified and the medical team and the healthcare team is concerned, you're the most junior, FY1, Foundation Year 1, also previously known as a house officer. Then you go your senior house officer, your SHO. That's anyone from an F2 and above. So F2, CT1 and CT2. So that's core surgical trainee 1, core surgical trainee 2. Now, this again, when you go into surgery, if you want to do surgery, you apply after F2, you apply for core surgery. Or now they run through courses, but the traditional way is the core surgical training, and you do 2 years of that, so you're CT1 and CT2. And the registrar is basically ST3 above. So you finish your core surgical training and you're in that specialty of general surgery, vascular surgery, orthopedics, neurosurgery as an ST1, and you progress that way until you're a consultant. Now, I have mentioned also specialist nurses, physiotherapists, and physician associates, and they're very valuable members of the team, and use them. They help a lot. They're very experienced a lot of time because they've spent time on that specialty for longer than you. And also, I just highlighted as well that registrars and consultants, especially in general surgery, most of the time are either in theatres or in clinics. They're either in theatres or in clinics, so sometimes it's difficult to get hold of them, but there's loads of hospitals have systems in place on who you should escalate to and who you can contact. And sometimes if it's an emergency, you can you go into theatres respectfully, and whenever it's a good time, and you mention to your registrar or consultant what's going on the ward. So make sure you're aware of that. That's it. So now we go through an example of a day what might look like in general surgery, and this is like roughly based on what my job was like when I worked in a DGH in general surgery. So if you just focus on one column first, so on a normal day, you do your 7:30 in the morning, you go usually in a room and you get handover. The handover is given by the night team, so there's usually a night, again if it's a small hospital, night registrar and a night F1 and an SHO. And obviously, whatever has happened through the night, any new patients that have come in through A&E, or any new patients, or any patients that have had emergency surgery or things like that were on the ward, obviously they hand that over to the day team. That's a consultant that's on call, the registrars and the junior doctors that are around. Excuse me. And then the ward round starts. So as an example, ward round starts. And again, this is just an example, like your handover can start at 7, your handover can start at 8, and then you finish your handover at 8:30. So this is just an example, right? So the ward round starts, and general surgery ward rounds, believe me, are very fast, are very quick, are very fast. So by 8:30, 9 o'clock, half an hour, 1 hour, tops maybe hour and a half. I think that's pushing it, probably not. Your ward round ends. Your ward round ends, and you've got a list of jobs. Again, those jobs include the things that I've mentioned. So calling different specialities, making sure that bloods are taken for a patient, and we're keeping an eye on the U's and E's and LFTs. As an example, a few patients might be getting discharged, to make sure that discharge letters and their TTOs are in place. And you might have to call a relative of a family because of XYZ, because of complications, or you just need to speak to them, or they want to speak to a doctor, etc. And throughout the day as well, when jobs get generated, throughout the day, what happens as well, like other jobs get generated throughout the day that might not be part of the ward round. So someone might become ill, someone might develop a complication suddenly, or like a relative wants to speak to you, or someone else, another specialty wants to speak to you. So don't expect that the only jobs you get during the day is the ones that are generated during the ward round, but you get jobs throughout the day as well, from different places. If you're on call, so if you're on call, 7:30 handover, ward round starts, and then at 8:30 to 9 o'clock again, end of ward round, and you go do your jobs. And I guess it's exactly the same thing until say 5 o'clock. And the 5 o'clock, obviously, I just put that as a generic marker. It could be 6 o'clock, it could be 5:30, whatever. So 5 o'clock finishes, and then you take handover as being the person on call from the day team, from everyone else, except obviously yourself. They hand over any jobs that's left, that they're just chasing bloods, chasing images like x-rays, abdominal x-rays, CT scans. Maybe there's an admission that's coming in later on the day and they ask you to clerk them, etc. And then you do that till 7 o'clock, 7:30, 8 o'clock, depending what time your on-call shift finishes. And then you hand over everything to the night team. And you hand over everything to the night team. Same thing, if there's anything outstanding, like chasing HS x-rays, chasing bloods, chasing CT scans, etc. Usually jobs like speaking to different specialities, jobs that, for example, calling care homes or things like that, usually are not left to the night team, because those jobs really you can't do at night. So the night person is really to troubleshoot, to make sure everything is chased, to make sure any very unwell patients are looked after, but the other jobs are usually taken care of during the day. And then the night shift, similarly, you take handover, say, as an example, 7 o'clock, and you go all the way till 7:30. General surgery, depending on where you work, if it's a nice quiet hospital, you might be able to get a couple of hours sleep. You might be able to, if the wards are quiet and there's emergency surgery going on, you might, if you're interested, you might ask your consultant registrar, can I join you in theatres? And you put your bleed to one side, and if you do get bleed for something urgent on the ward, then you obviously descrub and you go. The bot depends on your trust, depends on your relationship with the registrar and the consultant, which I would advise you to obviously take benefit from, especially if you're into surgery. And yeah, so those are just examples of what your shifts might look like in general surgery. And obviously breaks are included in that. So whenever you have time, you go take a break, you have a coffee, lunch, but then obviously you'll know there's no such thing as a set time of break. You might be really busy and lunch is at 3, you might be really busy, lunch is at 4, or you might have a quiet time, you can get a coffee at 11, a coffee at 12, and a lunch at 1. So it really depends where you work and what your workload is like. Fine, so now going a bit medical, some emergencies that I need you to be, that in general surgery you should be aware of. Again, this list is not exhaustive. There's more stuff to be aware of, more things to know, but this is just emergencies that I remember in F1 when I did my general surgery rotation, kept happening and you shouldn't really miss, otherwise it can be quite catastrophic. Fine, so sepsis, bleeding, high stoma output because you work in general surgery, so a lot of them have stomas, a PE/DVT, a PE obviously more urgent, and an ileus and a stomatic leak and mechanical bowel obstruction. The reason I put those 3 together is because usually they present very similar. Obviously, bowel obstruction and stomatic leak being the emergency, in ileus is usually treated more conservatively, but you need to be aware of how to recognize them, right? Fine. So when should you suspect these things? So let's take them one by one. Sepsis. You go see a patient post-op, has had an operation, part of their bowels removed, gallbladder removed, appendix removed, whatever. You see the nurse calls you, doctor, could you please come and review this patient? You go, they have a high heart rate, their respiratory rate is high, they have a high or low temperature, because remember in sepsis, you can either have obviously sepsis or cold sepsis. They have infected looking wounds, or they have any other sources of infection, on any other sources such as CVC lines, so central lines in, or catheter in, so anything that can be a source of infection. And they have this high temperature, and you check their inflammatory markers, they've been steadily going up, so you suspect sepsis. Okay, so you suspect sepsis. Not all of this might be present, more than this might be present. This is just an example. Bleeding. Again, surgery, very important. One thing that all surgeons are very, very scared of, obviously, rightly so, is bleeding. So you go in, you examine the patient, they have a low blood pressure, they have a high heart rate, and you've been seeing that the HB on the FBCs are trending downwards. So, and they have a deranged coagulation screen, for example, and maybe they've had bleeding during the surgery itself as a complication. Again, all of this can be present, some of it can be present, or more can be present, but there's something to keep in mind and be suspicious of when you see these signs, right? High stoma output, because it's important, because the patient can get really dehydrated, because if they have a lot of fluid through the stoma, sometimes we think fluid only obviously through, say, vomiting or sweating or through the catheter, but obviously when someone has a stoma, just like if someone had severe diarrhea, they can lose a lot of their fluids, a lot of their electrolytes, so make sure you keep an eye on that. Keep them dehydration is a sign, sorry, we'll go through the management in a second. Blood pressure is a sign, low blood pressure, and you can physically see, and you can ask the nurses if they've kept a chart that you see like there's been a lot going out of the stoma bag. And then P, another killer to be aware of, high respiratory rate, low SATs. The patient needs like 5 liters of oxygen to maintain the saturations. They're post-surgery, so again, risk factor. They're not on a correct VTE, meaning they're not on correct prophylaxis of, say, tinzaparin or Clexane, whatever obviously your trust uses. And they're not, that hasn't been correctly prescribed or hasn't been correctly given. Again, risk factor. They have a history of clots, risk factor. And you do an ECG, and it's in sinus tachycardia. Remember, sinus tachycardia is one of the most common signs, or the most common sign on an ECG for someone with a PE is sinus tachycardia. And then finally, ileus or bowel obstruction. So you have a patient not open their bowels for 2 days, 3 days, and also obviously that could be constipation, but they haven't also passed any wind for 2-3 days. You feel the abdomen is distended, it's painful, it's hard and tender, so straight away you suspect bowel obstruction, ileus, or an anastomotic leak, because that could present that way. So again, just to mention, these are rough guidelines to keep in mind when you see an unwell post-op patient. Make sure you examine them thoroughly and base your diagnosis on the clinical findings. That is, that all these signs might be present, some of them might be present, or more might be present. Or, so it really depends on the patient, and when you go see the patient, you make a holistic judgment on what diagnosis it possibly could be. And you aid your suspicions, obviously, with tests, imaging, and things like that. So the things that you should do, when you see these things. Patient comes in with, patient, you suspect sepsis. First thing you do is you suspect sepsis, you escalate as an F1. Do not be afraid of escalating. It's better to escalate early, better safe than being sorry, okay? So you escalate, you initiate sepsis 6. What's sepsis 6? We all know of it. So 3 in, 3 out. Give them antibiotics, give them fluids, put them on oxygen, take a lactate, send blood cultures, and measure urine output, okay? So, but prior to giving the antibiotics, again, a small little thing to be aware of is make sure you check their allergies. You might start giving them comoxiclav or Talocin, and they're penicillin allergic, okay? So make sure you check for antibiotics. And consider imaging, and document. And documentation is very important, so make sure you document well. When I say escalate, you call your registrar and you say, look, I've got this patient. They've got they've got like a high heart rate. They have a high temperature. The inflammatory white cell is 35, as an example, 35. I'm initiating sepsis 6. Is there anything else you want me to do? I'm also getting an X-ray, for example, just to see of the source of the sepsis. Maybe it's in the chest. I'm getting also a chest X-ray. Anything else you want me to do? I would really appreciate if you come review the patient. You should always ask for your registrar, someone senior SHO, to come and review the patient, because they should come see the patient really. It's not like you've manage the patient and they say, okay, fine, he's managing it or she's managing it well, that's all fine. No, they should come and review the patient if someone's really unwell. And so ask that kindly, like, you can come review the patient. Bleeding, again, escalate. Of course, a patient, low blood pressure, high heart rate, suspecting bleeding. These are the things I'm going to do. I would really appreciate if you could come and review the patient. Anything else you want me to do in the meantime? You send an urgent FBC. You do a VBG. So VBG obviously is a venous blood gas, because that's more easy. You get the HB more quicker on a VBG than obviously sending lab bloods. So you quickly send it off, and you see obviously if the VBG is low, so you can start doing things, right? You check if the patient has a valid group and safe. Most of the time, because they're on general surgery, they will, but it's always good to double check, call transfusion lab, say this patient we're suspecting bleeding, do they have an active group and safe? If not, then you can send a blue bottle. It's usually a blue bottle that you send off quickly. Again, these are good to be it's good to be prepared, right? And consider activating major hemorrhage protocol. This is obviously it might not be you that activates this. It might be a senior SHO or registrar, the consultant, but when you're there, something to consider, keep in the back of your mind. VBG comes back and the patient has a hemoglobin of 40, for example, and they've been trending downwards. So there's something to keep in mind, and maybe if no one else thinks of it, you could perhaps mention it if it's not a protocol for you to initiate the major hemorrhage protocol, but someone more senior to do it. Then it's something you can mention, for example, like, should we consider activating this protocol? And every hospital's protocol is slightly different and involves different things. We won't go into too much detail, and again, document well. High stoma output, escalate again, check their electrolytes. Are their U's and E's deranged? Something low sodium, low potassium. You replace the electrolytes. You start them on IV fluids. You ask the nurses for a strict fluid input and output chart, and you document. The reason I say escalate and then document at the end is because the things that you do in the middle, these are the things you expect. A lot of times, a lot of these things will be done by other people that are there as well. And when you escalate, the registrar might come quick, but this is something to keep in mind, and what you at the minimum is expected to do. You might not do any of these, and others might do them for you or initiate these processes. But if you know them, then it makes your life easier and also impress your seniors. So don't be scared. And there are lots more to do, for example, for these patients with these conditions. But again, you would hope that at that stage, someone more senior has intervened, and that's when your learning starts as well. That you see what they do. So when you get to that stage, that's when you take over. Then, if that makes sense. So you're F1 now, and when you registrar, you do those things that you see them doing. So, for example, bleeding patient might have to go back to theaters. PE, again, escalate, arrange a CTPA. Check if the VT is correct, check their clotting screen, and you document. Bowel obstruction, again, escalate, you keep the nail by mouth, so if they're drinking or eating again, you stop. Consider an NG tube, again, that once you escalate and you speak to your registrar, they might say to you, okay, put an NG tube in, and if you haven't done one, it's okay. It's okay to say, look, I haven't done an NG tube, I haven't inserted one, could you please come in as soon as possible, because I don't know how to do it. That's all fine, that's okay, you're there to learn. Start them on IV fluids, consider imaging, and document. So these are the things to keep in mind. As I said, your registrar might say, can you do these 2-3 actions on top of that? Fine. Or don't do this, I'll come and assess myself and then do that. For example, I don't know, certain imaging, considering certain imaging, they might say, no, don't do it now. Or even the CTPA, don't do it, let me see the patient first, and then we'll think about it. Fine. But as long as you escalate early and document well. Fine. So approach all your patients in an ABC manner, with airway, breathing, circulation, stability, exposure, things like that. So the things that you're usually taught in first aid and ILS and BLS and ILS and ALS. So make sure you always approach your patient that, because that's the safest way, and hopefully you won't miss anything when you do it systematically like that. And once you get good at it and you see more and more patients, then obviously you know how quickly to go through each of those components. Escalate early and document well. Can't stress that enough. And get familiar with your hospital protocols and use them as a guide. So, for example, with sepsis, certain hospitals have certain antibiotics that they like you to use, or certain anticoagulation, etc. So get familiar with them. Ask if you don't know, and they're usually on your hospital in the hospital intranet, so you can get access to them. And it's good maybe to read them beforehand if you got a minute. But yeah. So yeah, I think that's it. So in summary, work hard. Work as a team, include all the members of the team. Be humble, don't be arrogant. No one likes arrogance. Be confident, but don't be arrogant. There's a fine line, and sometimes it's good to be on the humble side than the arrogant side if you don't know where the line is and you're just finding out where that line is, but be humble. Always ask questions. I can't stress this enough. Even if you think your questions sound dumb, because it's you that thinks that, no one else. Sometimes you might find yourself in a group, you think, oh, I don't want to ask this question because if I ask, it sounds dumb, and they'll think, oh, this is a dumb person. But someone else asks them, and everyone's like, yeah, thank you for asking that. And then you feel dumb to yourself. You're like, I was like, yeah, well, that was my question. I should have asked it. Because sometimes what happens, again, sometimes, just as an example, when you're a third year medical student, you think you have a question, you think, oh, but I should have known that when I was second year or first year, so I'm not going to ask it. I'll sound dumb. When you're fourth year, you think I should have known that when I was third year. When you're final year, when you're F1, I should have known that as a medical student, and so on and so forth. And what happens, you'll never learn because you always think I should have known that. So if I ask, I'm going to sound dumb, so I refrain from asking. No. That's not, you ask anything, even if you think sounds dumb, ask. Even something simple, you might have forgotten it, you might have known it, you might have written it in your exams, you've passed with flying colors, but at that moment, at that stage, you've forgotten it and you need someone to remind you of it. And if someone obviously makes fun of you of that, whether it's a registrar, consultant, or some of your peers at the same level, that's on them. That shows their character, not yours, okay? So don't be afraid to ask questions, no matter how dumb or stupid you think they sound, they are not. All right, because with that answer to that question, you could save someone's life one day. Own your patients. We've been through that. So own your patients, know your patients. Why are they on the ward? Who are they? What are they waiting for? Etc. Etc. Escalate early, even if it turns out to be okay. As I mentioned, escalate early. It's better to be safe than to be sorry. Okay, escalate early. Always use an ABC approach. Okay, always use an ABC especially when you're first starting off. When you ask to see a patient, use airway is clear, breathing is clear, listen to their chest, listen to their heart, etc. Document well, because documentation is very, very important. One, so people know what's happened clearly, and secondly, so if things, God forbid, do go wrong, you have at least taken the right steps and you can clearly prove that by your documentation. So documenting well is very important, okay? Familiarize yourself with your hospital protocols, as I mentioned. So whenever you get time, read through them, just the basic anticoagulation, antibiotics, and things like that. And finally, enjoy, learn, and grow each day. You're there to learn as junior doctors, F1, F2s, SHOs. You're there to learn, and the senior registrars and the consultants are there to teach. So, as I say, it's okay to ask questions. It's okay not to know something. It's okay not to know a lot of things, and a lot of things you won't know. So it's all fine. It's all okay. Enjoy. And if you're doing a job that you don't enjoy in particular, that's fine as well. It's only 4 months, and you'll go to another job. And if you don't like the whole foundation program in total, it's only 2 years. So, and trust me, even if you don't enjoy it and you're thinking, oh, this is not really for me, you've gained a lot of good, valuable skills that you can use outside of medicine or in different specialties. All right. So thank you very much for listening. I hope that was of some use. I hope it was beneficial. This talk will go on YouTube. We will hopefully upload it tonight or tomorrow. And again, any questions you guys have, obviously I'll answer some now. And anything you can ask through the Cut the Stitch Instagram page, send us an email, or contact me directly at Basir Kunduzi on Instagram, LinkedIn, or Twitter. I'm more than happy to ask any questions. Let's go. So let's go to chats first. What's been said? Great. Questions. Fine. Yes, it will be recorded. And then let's see the questions. Is there any way to access previous talks? So we have had 2 talks so far. The vascular surgery talk, unfortunately, the speaker did not wish for it to be uploaded onto YouTube, so we have to respect that. So it's not available, unfortunately, but we'll have more vascular talks. I promise we'll get more vascular surgeons on board to give us more talks and teach us. The acute abdomen is on our YouTube page, and also the link of that is in the Instagram bio. And also this talk will go onto YouTube as well. So what are the key points for surgical admission clerking? So when you clerk, very good question. So clerking usually done in A&E, or if someone comes electively, they're in a day ward or something, and you go clerk them. So the important things are to ask, obviously, why are they here? What's happened? A basic history. Patient might say, for example, you go to A&E, patient has obviously abdominal pain, the A&E has called the surgeons to come and clerk the patients. Why are they here? If it's a pain, what's the nature of the pain? And you go through your Socrates, which is, again, a different talk by itself, but just like, where's the pain? Does it radiate? How bad is the pain? Etc. etc. When did the pain start? Is this the first time they're experiencing this? If it's an elective admission, and I'm just going basically through it because it's actually quite long to go through the whole basic admission clerking. So history of their presenting complaint. If it's an elective operation, for example, someone is having their gallbladder removed, why are they having it removed? What were the symptoms they were experiencing? What's their past medical history? Do they smoke? Do they drink alcohol? Do they use any recreational drugs? any family history of any conditions, allergies, and what medications they're on. So you obviously start examining them then. So you do a full examination, abdominal, chest, heart, and take it from there. So that's basically basic summary. So just the regular clerking, really, and you focus on the particular symptoms. If it's to do with pain, you ask specific questions. Very important, obviously, if they come in and you suspect surgery, then you send obviously you always send FBC, full blood count, using these LFTs, but make sure you also add a clotting screen, and you also add a group and safe when you see them first to their bloods. So that's done and ready. Okay. So those are the key points. I hope that answers the question a little bit. Thank you for the lecture. Where would I find the recording? Afterwards on YouTube. You could find on YouTube. What was the choice of pursuing medicine, surgery? Was the choice of pursuing medicine or surgery hard for you? Was major job for surgery? So that's more of a personal question, which is fine. It wasn't too hard pursuing medicine for myself. It was a bit cliche, but I always wanted to do medicine. And towards the end of medical school, I decided to do surgery because I saw renal transplant surgery and I absolutely fell in love with it. And I love everything about surgery. I'm giving a talk to South African medical students on Friday that you're more than welcome to join. It's the Stellenbosch University talk. As I said, I've got a post about it on my Instagram page, and then you can see where that is and how to join. It's on Microsoft Teams, on kind of the journey of me wanting to become a surgeon and some of the entrepreneurial things that I do as well. So more than welcome to join that. And also, again, please ask me privately, and we can have a discussion about that as well. And if you want any tips or any questions in particular, I'm more than happy to answer. When you escalate, would you speak to your SHO first, or would you go to the reg? So very, very good question. If you have an SHO, I would speak to the SHO. Always escalate one up. However, if your SHO is not available, if your SHO is not present, then go to the reg. And if you, for example, see sometimes you work in a trust, so the SHO might not be as senior, it might be just 1 year senior and they're busy with their own patients, call the reg straight away. If you feel that, for example, something is really bad, the patient's really deteriorating very fast, call your reg straight away and then let your SHO know afterwards. So depending on how bad the problem is, the availability of your SHO, and how senior your SHO is. But generally, if you want to escalate something, then the best way to escalate is to go to one above you, which is your SHO, and they'll go to the reg. Or they might be able to deal with that problem because they're more experienced. You might be like, oh, it's not that serious, but you think it's serious because you know that experience, which is fine, it happens, and you should be worried. And that's how we learn. Hope that answers that question. Will there be a feedback form for certificates? Unfortunately, I don't think we can give certificates for this talk. Actually, I don't feel qualified enough to give you certificates for a talk that I gave. However, good that you mentioned feedback. I will put a link and a code. If you guys can go to that link and then type that code in, it will give you a set of questions, which is feedback for me, and will help me greatly for my portfolio about this teaching. Is it hard for IMGs to get into surgery specialities? Again, that's something a bit off topic, so we can ask me that privately and we can go through that. I have not too much experience in that, but hopefully I can guide you into the right direction. So if you message us, we can see if we can help you with that. Unrelated, but could you inform me about the role of having publication and specialist recruitment? Is it necessary to have them? Again, we can have a whole talk about this. Yes, publications are somewhat important. There are other things that do count towards getting into a specialty, whether it's surgery or medicine, but publications do play a big role. So if you have any good publications, if you can get involved in research, if you're in university or if you're a doctor, then by all means do. They're not the be all and end all. So if you don't have them, not all hope is lost. But it is something good to have and somewhat important. What do you reckon makes a good medical student on placement? Excellent question. Get involved. Be careful. One thing though, be careful though not to be too, I mean, like, what's this? What's that? What's that? When they're really busy. So make sure you time it right. So whenever you see, for example, someone a bit free, ask questions, get involved. What can I do to help? Is there anything I can do? Is it okay, for example, say, for example, you join you're there for a week, for example. The first day you go, you observe. The second day you help out a little bit. Third day, you, for example, before the ward round starts, you ask the F1, is it okay if I take some notes, type some notes in for some of the patients while they go around so I can improve my note-taking skills? And I'm sure they'll say, yeah, of course, they go for it because you'll help them. And then maybe with bloods, it's okay if I do these patients' bloods, and so you get practice in that. So things like that. So you can, is it okay if I help with the jobs? Is it okay if I speak, for example, to the specialty while you're sitting next to me? and obviously discuss a patient with a specialty as a medical student. And I'm sure they'll be more than happy to allow you to do that. And they should actually encourage you to do that. So that's the best way to get involved, get really get part of the team, be with them. But to be said as well, like, don't, if the team is very, very busy, then sometimes it's asking too many questions at inconvenient times might not place you in a favorable place with them. So be careful, because those are the mistakes, as I said, we've made and my colleagues have made. So I think that would be a good medical student on placement. Any recommended readings before starting the job? People do read stuff like chapters of Oxford Handbook and things like that, but you've done medical school and there's, to be honest, nothing else to add really. You go and do the job and you learn a lot during the job. So I don't think there's anything that I would recommend that you could read beforehand. If you want to read some of your medical school lectures or things like that beforehand, then by all means. Otherwise, there's nothing that I can really think of specifically for you to go and read, but to go and literally learn on the job. What was the application? It was to general surgery like. So I haven't applied to general surgery as such. So my story is I've just finished F2. I'm going to take a year out called an F3, but also do something called a junior clinical fellowship in renal transplant surgery in London. So I'm moving back to London, and then apply for surgery. And once I get to those stages and things like that, then we can talk about that further. But I don't think I'm qualified enough to talk about an application in general surgery if I haven't done one myself or am in surgery myself yet. But there are plenty of people you can ask, and as I said, once I get to that stage, more than happy to answer that question. How beneficial are the observerships electives taken as an undergrad? They're very beneficial. One, for yourself, for your learning. It really can show you whether you like that specialty or not. If you do like that specialty and you do an observership or elective in it, it shows interest to people you apply to. So, for example, you apply to certain certain specialties or certain programs, then it does show, for example, that you're interested in that and that you're really keen to do that specialty. And it's good points on your CV. So they are very beneficial, and I would definitely recommend it. What's the junior clinical fellowship? Okay, now getting to off topic. So by all means, feel free, and also I think we're a bit over time. A junior clinical fellowship, because I feel bad if I don't answer the question. A junior clinical fellowship is basically a 6-month or 1-year job that you do, and you're basically an SHO level at a trust, at a hospital in a certain department. It's not a training post, but you do the job as, for example, someone who might be in training. In some places you might be doing the job as of an F2. For the hospitals, it's good, for example, they can fill certain gaps in their rotas. For you, it's good as an experience and to see if you really like the job, or to, for example, have that gap to do other research and things like that. So, but we can talk about that in more detail again, maybe in future talks. So I hope that was useful. I hope you guys find it useful. So I'm going to put in the chat right now. So if you guys go to medgate.co.uk/feedback, and then you type in this code. Just 1 second. Six zero one nine 6019 1887. 6019 1887, and that should give you a set of questions with regards to this talk, and that would help me greatly if you guys could fill that out as a form of feedback, the things you guys find useful and the things that you guys didn't as such. Let's see. And also, please go to MediGate.co.uk. As I said, sign up. We're a platform that give you all the courses. We're working to get you all the courses and conferences on one platform. So if you want to attend certain surgical conferences or courses, you can find them easily on MediGate. It's all tailored and personalized to you. You make an account for free. And also it's a good place to keep your certificates and teaching feedback and things like that secure. So go check it out. Check our Instagram page, go to the website, sign up, have a play around the website, send us some feedback. We're starting up, so that's the things that we're developing, but please sign up. It's all free for now, and I hope you enjoy it. And if you have any questions, then again, you can get in touch with me through all those means that I mentioned. looking forward to having you in our future talks. And please join our talk on pediatric fractures on Thursday, I believe, on Thursday, 7 p.m., given by an ST7 in trauma and orthopedics. And it's again a very good talk very good talk to listen to. Very good talk to listen to if you're interested in orthopedics, but also if you do an orthopedic job or if you're doing an A&E job, which most of you will, because pediatric fractures is one of those topics that's that you need to be aware of. And if you can recognize certain things in A&E and on the ward necessarily if you do pediatrics, but if you on the A&E, then that's very important. So I hope you guys enjoyed it. Thank you very much for listening, and see you guys later.